Good evening, ladies and gentlemen. I'm Gavin Lambert. I'm the Director of the Iverson Health Innovation Research Institute here at Swinburne University of Technology. I'm thrilled to be here this evening and privileged to welcome you to Swinburne's annual Barbara Dicker Oration. I would firstly like to respectfully acknowledge the traditional owners of the land on which we gather and pay respects to all Aboriginal community elders, past, present and emerging, who have resided in the area and have been an integral part of the history of this region. A special welcome to Mr. Ian Dicker AM and the Dicker family, former Victorian Premier, the Honourable Ted Baillieu, former Chancellor Dr. Bill Scales AO, former Chancellor Emeritus Professor Ian Wallace AM, Chancellor Mr. Graham Goldsmith, Vice Chancellor Professor Linda Christensen AO, members of the Swinburne University Council, members of the Swinburne Executive, others distinguished guests, ladies and gentlemen. At Swinburne, we're privileged to have some of the world's leading academics and researchers working towards identifying, understanding and solving real-world health challenges across the entire human lifespan. One of our strong suites is in research focusing on a range of mental health conditions. Much of the work in this area is made possible by the philanthropic support of the Barbara Dicker Brain Sciences Foundation, which was established in 2012 to support multidisciplinary mental health research. The Foundation supports research across a wide range of conditions, including schizophrenia, sleep disorders, dementia and depression. Tonight, we once again celebrate Barbara Dicker's legacy and the generosity of the Dicker family. The Foundation is enabling great advances in mental health and well-being, doing so entirely through philanthropic donations. I encourage you at the end of today's lecture, there will be a table outside and you can go and speak and learn about the work of the Foundation. Of course, we are accepting donations, small, large, whatever. We get those donations basically to support the ongoing research in mental health here at Swinburne University of Technology. We are certainly in for a wonderful evening today. To begin with, it's my pleasure to invite Ian Dicker AO to the podium. Thanks, Ian.
Thank you very much, Gavin. It's the time of the year when it's appropriate to sing. We're a happy team at Hawthorne, we're the mighty fighting Hawks. It's relevant because Barbara was born in 1936 in Hawthorne. Her two sets of grandparents lived in the same street, Barton Street in Hawthorne, and she really was Hawthorne. I was recalling today to myself that she, as a child, went down to Glenferrie Oval and with her father, who played baseball there in the morning and stayed in the afternoon for football. So Barbara grew up in the cricket stand, which probably doesn't exist from a very early age, and so she's walked and lived Hawthorne all of her life. She did. She died 8 years ago and she would be really proud of everything that is happening. She would be proud of her 3 children who are doing really well, her grandchildren, some of whom I've seen tonight, the way they're developing, and but most important, the work that Swinburne University are doing in research in the fields we talked about. Barbara was a physiotherapist and so had a very strong medical interest, and she would have certainly appreciated what the group of researchers have done and are doing. I do say that it has developed. We didn't have a plan at the start of what we wanted to do except for to pick the 3 topics we wished to research, but I'm pleased to see tonight the researchers present their work, which is a discussion which came out of one of our board meetings. How can we keep improving the night? And that's one I think that's really working well. One other thing that we're proud of is that we have now in our constitution, which doesn't exist, we have allocated 2 research programs each year to students, so it's not just for the professional researchers. So that's all evolution, and every bit of it Barbara would be very proud of. For those who've been here a number of years, I can say that this is the last time you'll see me, because again, Barbara would be proud of the fact that her eldest son, Dr. Tony Dicker, has taken over the chair of the foundations, and so next year, Tony, I'll welcome you to take this role. So please enjoy the night, and thank you so much for coming. We really look forward, Iris, to what you're going to present.
If only I knew the second line of the song. Thank you very much, Ian. It now gives me great pleasure to introduce tonight's speaker. Professor Iris Sommer is a best-selling author of 2 scientific books, has published over 250 academic articles on hallucinations, language, cognition, and psychosis. She obtained her PhD at Utrecht University in the Netherlands in 2004, examining brain imaging in schizophrenia. In 2011, she was appointed Professor of Psychiatry at the Utrecht University Medical Center. Currently, she is Professor of Cognitive Aspects of Neurological and Psychiatric Disorder at the Department of Neuroscience at the University Medical Center Groningen in the Netherlands. Professor Sommer's research interest is related to the association between cognitive dysfunction and also the activity of the immune system. She aims to develop new treatments to support people with cognitive deficits during their recovery from medical, psychiatric and neurological disorders. Please join me in welcoming Professor Sommer to the stage to deliver tonight's oration, The Phenomenon of Hallucinations.
Thank you very much. It's a great honor for me to be here. Thank you very much for this invitation and the opportunity to share my work with you here. Today I'd like to talk to you about hallucinations. But before we start off on hallucinations, I'd like to explain you a little bit about normal perception. In perception, the brain is key. We see, hear, and feel through our senses, but mainly with our brain. So perception is teamwork between the senses, or eyes, ears, the skin, nose, and the brain. And the two have to make it together. So the brain is very influential, and therefore we see what we expect to see. And sometimes we see what we are afraid to see. The way that normal perception works is that we pick up small pieces from our environment, just a few stimuli, and we fill up the blank. So we don't really scan the complete room in this case and then come to a conclusion, but we just pick up a few details and jump to a conclusion. So the brain adds a lot. And what it adds comes from our experiences, from our memory, from what we've learned, from what we expect, and sometimes also from our fears. So this teamwork can be pretty much towards one side or the other. And you can even perceive things completely with input from the brain. So for example, if it's dark, the eyes will not give you much information, and the brain has to make up much more. And you can even perceive with zero information from our senses and all information coming from our brain. And that's, for example, if we are dreaming at night. But you can also perceive completely from your brain when you're fully awake. And you might have had such experiences, for example, when taking heavy painkillers, or when you have skipped 2 or 3 nights of sleep, or when you were by yourself for a very long time. You can see it often in solo sailors, or in climbers on high altitude, and that's what we call a hallucination. So I'd like to share a very short part of a very nice movie with you. It's called Dr. Strange. It's on Netflix. If you want to watch it, please do. But I'll show you just a small fragment, which I think is a very good example of what a hallucination can be like.
I see through you.
I'll stop it here, and you have to watch Netflix if you want to finish it. It's just to give you an idea, and perhaps if you've had high fever, you might have had this type of experiences, seeing your hands malform or experiencing this high velocity. And of course, it can also be experienced by using some drugs. Now, hallucinations have typically been explained either in a religious way or in a paranormal way. But I'd like to explain to you the neuroscientific way. And I'd like to take you to the hospital, because I think hallucinations are quite human, and we all experience them every now and then in our lives. But if you are ill, and you have any disorder in the hospital, you'll be much more vulnerable. So in the hospital, hallucinations are ubiquitous. And as you saw in the small movie, hallucinations can be very frightening. So let's start at the emergency department, where people might come in with drug intoxication. So some drugs are specifically designed to make you hallucinate. But other drugs, for example, painkillers or anti-malaria drugs or anti-epileptics, are not designed to do that at all, but might give you that as a side effect. And it can be very frightening. Our next stop is the ear, nose, throat department. Now, I told you that perception is an interplay between the senses and the brain. Now, in hearing loss, the ears don't give that many signals anymore, and the brain has to make up for it. And that can be a reason to hallucinate. So, Mr. Dicker started with a song. I'd like to follow with another song. This is the Dutch hymn being sung to you by a little off-key child choir. So I'll stop them now, because I'd like to explain to you why I'm showing you this song. It was the hallucination of an elderly woman who had very bad hearing. And because her brain was making up for the missing sounds from the environment, she was constantly hearing the national hymn, the national Dutch hymn, being sung to her by a little off-key child choir. So quite the thing you were hearing. Only for you I can stop it right now, and for her it went on 24 hours a day. So even when she slept, she kept hearing this song all the time. And it's much like tinnitus, and also much like tinnitus, there's not so much you can do about it right now. So we're definitely looking for better cures, because now we can only help people to cope with these hallucinations, but we would really like to help them to get rid of them. So off we go to the next department. And what we examined in the hospital in Utrecht is how hearing loss is associated to auditory hallucinations. We found that the more severe the hearing loss, the more common the auditory hallucination. Up to 24% of people with severe hearing loss having this type of continuous hallucinations. Now, let's see what these people hear. It is often music, as in the example that I just showed you. 36% of the people heard music. But what I noticed, and what I think is important to know, about half of them heard voices. So typically, when a person hears voices and is bothered by them, he's often referred to a psychiatrist or psychologist. But I think it's important that we should also check the hearing, because that can also be an important cause of auditory verbal hallucinations. And in that case, if you can still improve the hearing, for example, by using hearing aids, the hallucinations may actually stop. So our next word is neurology. And in people with neurodegenerative disorders like Parkinson's disease and dementia, hallucinations and paranoia are frequent. And we investigated over 1,000 people with early onset dementia. And we found that at the beginning, when dementia is not severe, that hallucinations is usually not a problem. And in fact, the prevalence was quite similar to that in a healthy aged population. But if dementia becomes more severe, then we see the prevalence of hallucinations going up steeply. We also used EEG, which looks at the electricity of the brain, can measure it on the outside of the skull, to see which mechanisms are underlying this type of hallucinations in elderly with dementia. And we found that the electricity signals with which the nerve cells communicate become somewhat slower, and the slowing is associated with the hallucinations. Now you might think that hallucinations are specifically something for the elderly, because I showed you several cases of elderly people experiencing them. But that's not the case. They're also very frequent in youngers. And actually, on each department of the hospital, you will meet people that suffer from hallucinations. So let's go to the obstetrics department, and I'd like to tell you a little bit about postpartum psychosis. That can be quite a severe disorder that affects about 1 in 1,000 women who just gave birth to their babies. And the problem is that we tend to look a lot at the babies and less to the moms, but I think we should definitely screen the moms for this severe disorder, because it's completely treatable and people usually recover well when treated in time. Now, I've picked a short TED Talk of a woman who has experienced postpartum psychosis herself, and she can speak of it very well. I'll show you a bit of her video. It's a very brave video. It's on TEDx, and highly encourage you to look at the whole of it. Now, she's clearly traumatized by her hallucinations. She has seen awful things which gladly aren't true, but she saw them through her own eyes, and for her at that time, they were true. Now, this woman was diagnosed in time and recovered completely. She's now an attorney again. But sometimes this diagnosis is missed. And only 2 years ago, I treated a lady who came in my shift, in my night shift, and I got a phone from another hospital that they had lost her baby. And that's also how postpartum psychosis can end. So it's very important to screen for this disorder and to be aware that hallucinations are on every department, definitely not only on the psychiatry department. They're ubiquitous, especially in the hospital. So the hallucination champ of the hospital is the intensive care. It's because it has the most severe patients of the hospital. And in the intensive care, you can have kidney failure. You can have heart failure, but you can also have brain failure. And brain failure is something that we call delirium. Severely ill patients very often experience delirium. In the intensive care, it's about 1 in 4 who experience this, and 1 in 2 in the elderly. And it can be just like the small movie I showed you from Dr. Strange. You can feel this velocity, you can feel that you're being driven there or there, and you can see strange things happening, you can see faces change that can make you very afraid. And often people are traumatized who have experienced this. Now, the best therapy for delirium, you may think of some medicine or some device. It is a family member sitting next to you and holding your hands. That's the most effective therapy. But of course, preventing it is even better, and that's what we're working on at the moment. And then, of course, we cannot skip the psychiatry department. And there we see many people coming in who are experiencing hallucinations, and I'd like to focus on hearing voices, which is quite a frequent symptom. And it's not only there in people with psychosis, but also in those with severe depression, anxiety disorder, autism. It can accompany almost every psychiatric disorder. The trouble on hearing voices, especially for the patients we see in clinic, is that they can be very nasty. And I'll show you an example of what voices can be like.
hear us. You can see us. Stupid. You're so stupid.
I'm so stupid.
You're wasting time.
I just want to wake up.
We're your only friends.
Well, it's not nice to hear the Dutch hymn all the time. This is even worse. These are very personal things, and the majority of them is often negative. They can be positive also, but the people in hospital who want to get rid of them often hear these very nasty personal comments. And we have used functional MRI, so brain imaging, to see what's happening in the brain when a person experiences these voices. And this is an example of what we found, and I'll guide you around. Here's a little anatomy to help you find your way. If we go to this picture of the brain, so here's the eyeball, the nose, the ear would be here. There's quite some activity which you can see in red in this area, and you can see it here in the atlas, and that's a speech perception area. So if you're listening to me now and you understand what I'm saying, your speech perception area will be active. The patient in the scanner is hearing voices and understands what they say, so in his case also speech perception areas are active. This tiny bit of activity is on a very peculiar place, which is here in dark pink. And that's what we call the primary auditory cortex. So whatever sound you perceive consciously will activate your primary auditory cortex. And so does hallucinations. So this means that hallucinations are real perceptions. So private perceptions, they're not shared with anyone else, but you perceive it as you perceive sounds coming from the environment. There's no difference, and that's why it's so difficult for patients to accept that it's not really there, because you tend to believe your ears and you tend to believe your eyes. There's also quite a bit of activity in this area, and that's depicted here in dark green. Now that's the speech production area. It's Broca's area. And when I'm now talking to you, in my brain, Broca's area is active. So a person who's hearing voices experiences that as a kind of passive listening, but the brain scan tells you otherwise. The brain scan tells you that there's also speech production, and that might actually be the source of the voices that are hallucinated. We also looked, using fMRI again, what might trigger these voices. How do they start in the brain? Now this is a time axis. It's about 30 minutes that a person is in the brain scanner. And in the gray areas are the periods in which the voices have been heard. Now let's look what happens in the brain in the few seconds just prior to the voices. What can we see there in the brain? And then this is the picture that comes up. And I'd like to focus your attention on this area here, which is the hippocampus. Now we know the hippocampus to be very important for memory, especially for two things: to imprint new stuff that's important for you, that you want to remember in your brain, but also to retrieve memories that have been in your brain for adequate situations. So what happens prior to hallucination is that a memory is retrieved. That may not be too adequate, but it's there. It doesn't necessarily mean that what you hear when you're hearing voices is something that another person has said to you. It can also be a fragment, maybe heard on the radio, on television, or maybe even in a nightmare. But it's there in your memory, and you retrieve it, and that's what activates the voices. So this information provides us some coarse information about what might be going on, how voices can be triggered, and what's happening when a person hears voices. But many questions still remain. How exactly is the hippocampus activated at that moment, and how does it trigger the language areas, and how can a person hear multiple voices at the same time? And those are questions that functional MRI cannot answer, and we need a more sophisticated method to look into that, which could be MEG. And that's a method that can give you both very high spatial resolution, but also very high temporal resolutions, because brain processes are really fast and we need to track them in milliseconds. And that's the work that Susan Russell and her team are currently performing here in Swinburne. So, if we want to treat hallucinations, and we do want that, then we need to see what are the shared mechanisms that different patients have and how can we improve that. And one of these mechanisms we saw is decreased input, so sensory deprivation, perhaps by hearing loss or by vision loss, but also loneliness can be a very important factor because people are social animals. And if there's no communication, then the brain will just make up something for itself. So by improving vision and hearing, but also by solving the loneliness, hallucinations may diminish. Sleep deprivation is a very important factor, and that's something that we really do in the hospitals. So I think we should teach people in the hospital how to help patients have a good night's sleep by having private rooms, by having nurses that tiptoe through the rooms, or rather not enter at all if possible. Childhood trauma. Childhood trauma is particularly associated with hearing voices, much less with visual hallucinations. And this is a very important field for prevention. If we can prevent childhood trauma, we can prevent so many psychiatric disorders and also hallucinations. Intoxications are another joint factor. So I told you about some medications, but a lot of recreational drugs can also induce hallucinations. For example, cannabis, but also speed and cocaine. So let's look at the treatments. If we know some common factors underlying it, how can we treat hallucinations? And there are several options that we can just provide to anyone who's experiencing hallucinations and wants to get rid of them. First, we need to explain what's going on. Remember the fragment from Dr. Strange? He said, "What's happening to me? What are you doing? What's in the tea?" You need an explanation. You're used that you can trust your senses. And if you can't trust your senses, my God, what's happening? You need an explanation. So that's why this family member sitting next to you on the ICU is so effective. Someone to tell you what's going on, what you're experiencing, and how it might be cured. So that's the first step of treatment. Help to improve coping. There are several techniques you can use to have to be less stressed by these hallucinations. For example, mindfulness could be helpful. Improve sleeping, which can be a very effective therapy. Good company. I showed you that loneliness is an important factor, so if you can do something about that, that will definitely help. Improve hearing or vision. Cognitive behavioral therapy, which is a specific type of psychotherapy. And on several places in the world, although not too many, there are these specific voices clinics that combine all these therapies and provide a very intensive therapy to help people get over their voices. And there's one here at the Swinburne University, led by Neil Thomas and Susan Russell, that provides all these options to patients. We can also look at personalized treatment. So if we know exactly what's causing the hallucinations in one specific person, we can correct the underlying mechanisms. But we do need a lot of research to discover these mechanisms. There are many neurotransmitters in the brain. These are chemical substances that have a very careful balance, and when they're out of balance, they can easily elicit hallucinations. And one of them is dopamine signaling. And if that's too high, antipsychotic drugs may be a very good option because they block dopaminergic signaling. But if it's not the case, then they will only produce side effects. So you have to know in advance if this is the mechanism or not. Another mechanism could be decreased acetylcholinergic status. And you can compensate that by, for example, plasters that can restore your cholinergic status. Or serotonin status may be out of balance, and we can compensate that too, but we need to know on a personal level what's going on in the brain. Finally, there are also non-pharmacological options. I showed you the pictures of brain activation during hallucinations, and using TMS, which is transcranial magnetic stimulation, so a magnetic stimulation of the brain, we can exactly zoom in to that area where hallucinations provide activity and decrease activation very focally. So I think there are many possibilities, and we're definitely not done yet, but our aim for the next few years is to help all patients who want to get rid of their hallucinations to do so. So, for the work I showed you, I'm very grateful to my group in Utrecht and Groningen, and especially to two persons from whom I showed you some work. This is Masha Linse. She did the work on people with hearing loss, and Meenakshi Dawal, and she did the work on patients with Alzheimer's disease. Okay. Thank you very much for your attention, and thank you all for your support of research into mental disorders.
Thank you very much, Gavin, and thank you, Professor Sommer, for a wonderful oration. I think your dedication and hard work really shows through and is admirable. I was particularly struck by the apparent commonality and broad impact of hallucinations, some of the potential causes, and the approach and developing approaches to treatments. And really congratulate you on your presentation in a manner that non-academics such as myself can gain an appreciation and understanding of this important area of medical research into mental health. So I'd like to please ask you to accept this gift as a token of our thanks for joining us.
Thank you so much. Thank you. Thank you. It was a great honor to be here. Thank you.
And I would like to thank especially all of you for being here tonight. And once again, thank the Dicker family's generous support towards mental health research at Swinburne. This is an investment in a healthy future for all, allowing our researchers to delve deeper into disorders of the mind, to find new treatments and interventions. Philanthropy such as this is critical to our university undertaking transformational research. And I would ask those of you here tonight to continue to support the cutting-edge research happening right here at Swinburne so we can continue to create social and economic impact. At Swinburne, we are focused on becoming a leader in health research. In December last year, we officially launched our Centre for Mental Health. The Centre works to improve mental health through research, development, training, policy, and the dissemination of health information. Health innovations and research are at the core of Swinburne's future, and in recent years we've made a concentrated effort to strengthen our study offerings and research initiatives in line with our 2025 strategic vision. And as part of this vision, we've been developing a health precinct with state-of-the-art facilities building on Swinburne facilities and technology, including our neuroimaging facility that is allowing researchers to investigate cognition and brain function in more detail than ever before. There is no doubt that this would not be at all possible without the generosity of our donors, friends and partners. Your philanthropic support is enabling us to conduct life-changing mental health research that is truly shaping lives and communities. So once again, I thank you all for joining us this evening. I look forward to welcoming you to other events in the future and continuing to see our Swinburne community leading the way in innovation and addressing the challenges of our time. Thank you.